Hello. Now I'm going to demonstrate our ventilating bougie in a mannequin, and I'm going to compare it against the commercially available bougie, which is now commercially available ventilating bougie, which is available in the market. So in what way our bougie is different from the existing bougie is that this has a self-inflating cuff which inflates with positive pressure ventilation and it deflates after the end of positive pressure ventilation, so allowing the passive expiration happening around the bougie, outside the bougie, into the oral cavity and into the nasal cavity. So first I will show you how this self-inflating cuff works. So this can be ventilated with this type of ambu or Lyrdal resuscitator, or it can also be used with the oxygen tubing directly connected in the inner socket. So now I'm going to give the demonstration with the Lyrdal resuscitator. Let me show that. Now you can see the self-inflating cuff inflates. So inflates with positive pressure ventilation, sealing the trachea from inside, allowing the remaining portion of the ventilated gases to escape through this orifice into the lungs. This bag will be the lungs of this mannequin. So first I will show you how much the ventilation is happening with the commercially available ventilated bougie which is available in the market, and then we will compare with our ventilating bougie. Yeah, you can remove this target, please. Yeah. Yeah. You can show the lungs. So that is the maximum ventilation possible with the commercially available ventilating bougie. Hardly any expansion of the lungs, because since it does not have a sealing mechanism, all the ventilated gas is coming out through the airway of the patient. Now I will show you how our ventilating bougie fares in comparison with the ventilated bougie which is available in the market. Can you remove the stylet, please? So much of ventilation happening.
Start.
Yeah. So now we can see how much the ventilation is happening with this bougie compared with the other available bougie, ventilated bougie which is available in the market. So now we can clearly see that almost 1 liter of air we can deliver into the lungs with each compression of the Lyrdal resuscitator. So similarly we can even directly connect the oxygen tubing from the anesthesia machine, and we can give jet ventilation, intermittent compression of the oxygen flush button in the anesthesia machine will intermittently give the oxygen into the lungs. So this can save several thousands of lives every year across the globe. So now I will show you how easy is it to interchange the railroad the endotracheal tube over the bougie. Yeah. 21 centimeter mark. So the cuff has come out very nicely. inflating the endotracheal tube. I will demonstrate the superiority of our Bougie compared with the existing ventilated Bougie when we are using the oxygen flush inside anesthesia in an anesthetized patient inside the operating room. Okay, so in the anticipated difficult airway, what we generally do is that if the patient is desaturating, insert the Bougie and we can connect the oxygen tubing from the oxygen flush from the anesthesia system into the distal end of the ventilating Bougie, and we can give oxygen like this. The main problem with the ventilating Bougie is that since it does not have a sealing mechanism, most of the oxygen will be escaping from the sides into the upper airway of the patient, and it will not really enter the lungs. How our ventilating Bougie differs in comparison is that since we are having a self-inflating cuff, when it is inside the trachea, when we are going to give the oxygen flush like this, it will be sealing the trachea from inside so that a large amount of air will reach the lungs. So I will demonstrate, since I don't have a mannequin today, I will demonstrate with this breathing bag. Okay. First I will show how much ventilation is happening with this normal ventilating Bougie and how the ventilation is superior with our ventilating Bougie having the self-inflating cuff. First I am demonstrating with the normal Bougie. First you can show here, then you can show here. I am inserting the tip inside the circuit. You can show that. I am just pressing the oxygen flush button. This is the tip of the Bougie is inside the trachea. Now you can see how much the expansion is happening in the reservoir bag. That is the normal ventilation which can happen with the normal ventilating Bougie. In comparison with our ventilating Bougie, I can show here. Here we can see the cuff nicely expanding inside the trachea. So this tube will be resembling the trachea and the bag will be resembling the lung. You can show it here properly. Yeah, here we can see the cuff inflating nicely inside the trachea. And we can show the expansion in the lung. So that much air is going inside the lungs with our ventilating Bougie when connected with the oxygen flush. So in a desaturating patient, when we are not yet sure about the oxygen, when we are not sure about the tracheal placement, this Bougie will help with the oxygenation immediately, even before we could railroad a tracheal tube inside the trachea of the patient. Thank you. For the cricothyroidotomy, I am palpating the thyroid cartilage and the cricoid cartilage, and here is the cricothyroid membrane. So I am just making a vertical stab incision, rotating the scalpel. Now I am just inserting the Bougie into the trachea of the mannequin. Just release it. It's going inside smoothly. Once it is inside, I am removing the stylet and I am starting the oxygenation. We can see how much the expansion of the lungs is happening. This easily more than half liter of oxygen can be given with each breath of the ambu bag, or even with the oxygen flush we will be able to give 500 ml to 1 liter of oxygen per breath easily into the lungs. After we achieve satisfactory oxygenation, something around 99-100%, what we can do is that we don't have to keep on ventilating like this. We can disconnect the ambu bag, pull out the Bougie till it is into the cricothyroid, then rotate the tip and bring it out through the oral cavity. This we can retrieve through the laryngoscopy from the mouth. So once the tip of the bougie is out of the mouth, we can railroad a tracheal tube. Just remove that connector. Railroad a tracheal tube, and once the tip of the tube is out, we will try to push the tube all the way inside using laryngoscopy till the tip of the tube is comfortably into the glottis of the patient. After it's inside the glottis of the patient, we will just pull out the bougie gently and gradually while simultaneously pushing the tracheal tube inside. Yeah. Now we can see that tracheal tube is comfortably inside the trachea. Now we can inflate the tracheal tube cuff. And we can start ventilating the lungs. I will once again show how much we can actually ventilate the lungs with the bougie. So when the bougie is in the trachea, we can clearly see that at the lip level only the blue color portion of the bougie is seen outside. If it is inside the esophagus, it will go till it is the dark color, red or black. So that is the amount of ventilation which is possible with this bougie into the lungs. So with this bougie, we can satisfactorily, and here we are hardly seeing any rent in the skin and the cricothyroid membrane because the diameter of the bougie is only 4.3 millimeters. So, and we don't even need to surgically close that wound. It will just, if you just put a dressing, it will just automatically heal in a few days. So we are avoiding the insertion of a 6-number tracheal tube into the trachea. We are avoiding that morbidity. We are able to maintain the oxygenation for short periods, and if required we can rotate it, bring it out through the oral cavity, and we can railroad a tracheal tube also. So this new generation bougie will be a fantastic addition both to laryngoscopy guided difficult intubation as well as for the front of neck airway access in emergency situations. Thank you.